Welcome to the virtual Regional Anaesthesia Workshop for Trauma and Emergency. This webinar is a collaboration between the UGRA team of the Emergency Department of HKL and the SIGRA team from the Department of Anaesthesia Intensive Care HKL. First and foremost, on behalf of UGRA, I would like to express our utmost gratitude to the anesthesia team in their tireless contribution in the effort to establish regional anesthesia in the emergency department. We would also like to extend our thanks to the sponsors, Aspen Medical, Getz Healthcare, Bebron, Intan Bhakti, Infinity Medical, Gemilang Asia, GE and IDS Medical Systems for their support of this program. The objective of this webinar is to provide clinicians a new modality of pain control in the emergency setting. RA is definitely not something strange in the world of the operating theatres, and we are very privileged today to have a panel of speakers who are no doubt experts in this field and also very eager to impart their knowledge and experience to those present today. For today's session, we will be listening to a series of lectures focusing on chest, shoulder, and hip trauma. Each of these sessions will be followed by a demo of the respective blocks. At the end of the lectures, we will have a live Q&A session. Throughout the webinar, you will be able to type in your questions at the chat box, and we will do our very best to accommodate all of them. To officiate the opening of this webinar, I would like to invite Dr. Mahada Abdul Wahab, the Head of Service, Emergency Medicine and Trauma, and Head of Department EDHKL, to give his opening remarks. Dipersilakan, Datuk.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. And a very good morning to all speakers and participants. It is my pleasure to welcome all of you to this first virtual regional anesthesia workshop for emergency and trauma. This event is jointly organized by UGRA EDHKL with Malaysian Special Interest Group of Regional Anesthesia. I would like to extend my gratitude and greatest appreciation to the organizing committee for making this workshop possible. To our eminent speakers and colleagues from the anesthesiology department, thank you so much for the ongoing support. Without you, this workshop will not be possible. To our sponsors, Aspen and B. Brown, thank you for your support and terima kasih dahun keladi. Lain kali, tolong sponsor lagi. Pain management, as all of us know, is a very challenging issue, and majority of our patients presented to ED with pain. And to manage pain, it requires sound fundamental knowledge and skills, and the need to increase the armamentarium to ensure multiple approaches of pain relief can be offered to our patients. Therefore, RA provides us another approach or methods of pain relief with much lesser side effect in comparison to conventional analgesia in a selected patient. Furthermore, incorporating ultrasound has made this procedure safer and accessible to many. This is another proud development in emergency medicine that, again, thank you very much to our colleagues that make it possible. We have been working very closely with SIGRA HKL in training our medical officers and specialists, and we have successfully instituted ultrasound-guided RA services in our emergency department for nearly a year. And we are hoping these services can be offered consistently with a very much safer practices at the back of our mind. Finally, again, thank you so much to all the speakers and participants. And with the word Bismillahirrahmanirrahim, I officiate our first virtual regional anesthesia workshop 2020. I wish everyone a fruitful workshop and a pleasant day, and may God continue to bless our effort. Assalamualaikum warahmatullahi ta'ala wabarakatuh, and have a nice workshop.
Our first speaker will be Dr. Ng Zetek, an anesthesiologist from HKL. He is currently a trainee in Regional Anaesthesia Subspecialty Program in HKL since 2019. He's actively involved in postgraduate teaching in HKL. Next up, we would have Dr. Sabri bin Dewa. Currently working in KPJ Rawang Specialist Hospital, Dr. Sabri had undergone a fellowship in RA in Shimane University Hospital, Japan. We also have Dr. Wan Nabila binti Nik Nabil. Dr. Nabila holds an International Diploma of Regional Anesthesia and Analgesia from University of Montpellier, France, and also a trainee in RA's in RA subspecialty in HKL. I would also like to introduce Dr. Khairul Izzam bin Muslim, an anesthesiologist in HKL. Dr. Khairul receives fellowship of regional anesthesia from Kyorin University Hospital, Japan. Has been a facilitator for various RA workshops since 2017. We also have Dr. Azrin Muhammad Azim. He is the convener of Malaysian SIGRA, Special Interest Group of Regional Anesthesia, and Dr. Azrin holds various portfolios including robotic surgery and training for the Masters of Anesthesiology. Last but not least, we have Dr. Amiruddin Nik Muhammad Kamil. He's a member of the European Society of Regional Anesthesia and Pain Therapy and is currently the Director of Regional Anesthesia Subspecialty Training in MOH. So we will move on to the first presentation of the day, which will be presented by Dr. Ng. The topic will be shoulder trauma. Without further ado, I would like to welcome Dr. Ng for his talk.
So today I'm going to talk about this regional anesthesia for shoulder. We can actually good regional anesthesia shoulder by blocking the brachial plexus via two approach. One is the interscaling approach. Number two is the supraclavicular approach. So for the interscaling block, we are actually blocking the brachial plexus at the area of the nerve root, okay, which is here, this level, right? So by providing a interscaling block, we will actually be blocking the distribution is mainly at the upper arm and the shoulder. So I can continue with my talk. Actually, so for the interscaling block, thank you. For the interscaling block, the sonal anatomy that we need to see is actually the interscaling groove. So here at the interscaling groove, the interscaling groove, the brachial plexus which is at the roots of the brachial plexus, lies lateral to the carotid artery and also the internal jugular vein. So the prevertebral fascia, superficial cervical plexus, sternocleidomastoid muscle are seen superficial to this the roots of the brachial plexus. The depth that is usually about 1 to 3 centimeters. It's a very superficial block. Okay. So this is the picture to show the brachial plexus at the interscaling groove, which we can identify the nerve roots of the brachial plexus. We usually look at it as a traffic light or butterfly sign. So this will be the brachial plexus, which is the body of the butterfly, or traffic light. Then this is the middle scalene muscle. This is the anterior scalene muscle. So usually what we need to do to perform this block is actually we need a high frequency linear probe, a short bevel block needle, which is about 22 gauge, and the length of the needle is usually about 50 mm. So the other equipment needed are standard monitoring, block tray, resuscitation trolley, and you perform the block under aseptic technique using a chlorhexidine 0.5%. Scanning technique, there are two techniques to visualize the interscaling groove. One is the medial to lateral technique. The other one is to trace back from the supraclavicular fossa. So the medial to lateral technique, usually the patient will be lying in the supine position with the head turned 45 degrees towards the contralateral side. You place the probe on the level of the cricoid cartilage in the transverse to obtain a transverse view. Then you slide medial to lateral. So this is the usual position of the probe on the neck and the patient lying with the head turned away from the side to be blocked. So the first view you'll see is the trachea with the carotid artery and the sternocleidomastoid muscle. And as you slide laterally, more and more lateral, you start to visualize the anterior scalene muscle coming into the view of the ultrasound. As you slide more lateral, the middle scalene muscle also come into view. So in between the anterior scalene muscle and the middle scalene muscle are the roots of the brachial plexus. This is where we will do the block. How about the tracing from the supraclavicular fossa technique? The patient usually also same position in the supine position with the head turned 45 degrees. Then for this technique, you place the probe over the supraclavicular fossa and you identify the brachial plexus lateral to the subclavian artery. Then you slide your probe in a campanile direction. So this is how we place the probe in the supraclavicular fossa, and we identify the brachial plexus lateral or to the subclavian artery. Then as you slide your probe to the campanile position, the anterior scalene muscle and middle scalene muscle come into view, and you'll see the whole roots of the brachial plexus. So how do you identify which nerve root is which? So usually you can increase the depth and look at the transverse process to differentiate which is the C5 to C7 nerve roots. Usually the C5 and C5, C6 transverse process are U-shaped, whereas for the C7 transverse process, the anterior transverse process is not present. You are not able to visualize it. So this is how we differentiate the nerve roots. And for your information, sometimes the C5 and C7 nerve roots tend to split, and you may misinterpret as two nerve roots. So if you inject between the two nerve roots, you might be injecting at the one root which split the two, and this might cause nerve injury. So this is what I meant just now by differentiating the nerve roots using the transverse process. For C5 and C6, it is U-shaped. C7, the anterior transverse process cannot be visualized. So the other thing is you need to be careful is blood vessels. Usually there are a lot of arteries that transverse this at this level. Means some of it being the dorsal scapular artery, superficial cervical artery, transverse cervical artery. So this is a picture, ultrasound view of the interscaling groove. This is the interscaling groove, the scalenus muscle with the roots of the brachial plexus. However, there is the transcervical artery superficial to it. So this will make the block difficult. So how do you conduct the block? First, you confirm the landmark via ultrasound, and then under aseptic technique, you do an in-plane lateral to medial injection with aiming the needle between the C5 and C6 groups. A subtle pop will be encountered when the needle enters the interscaling groove. So the objective of the block is to place the infiltrate local anesthetic between the anterior and middle scaling muscle. A successful block is determined by the plexus being pushed medially with hypoechoic spread adjacent to the nerve root. For information, this complete circumferential spread around the plexus is not necessary for a block to be successful. All right. So this is a picture to illustrate the block. So we place the LA. The needle will transverse the middle scalene muscle. That should be placed between the C5 and C6 nerve roots, and the LA should spread along between the middle scalene muscles, pushing the nerve roots medially. As I say, complete circumferential spread may not be necessary. So dosages of local anesthetic, usually the volume of local anesthetic we use is between 5 to 10 mils, because with ultrasound we can accurately place the local anesthetic, so we can reduce the volume required to produce the block. So for the concentration of local anesthesia, if you are doing a surgical anesthesia, you might require a higher dosage, a higher concentration, sorry. Ropivacaine between 0.5 to 0.75%, levobupivacaine 0.5%. However, for analgesia, you can use a lower concentration, ropivacaine being 0.2, levobupivacaine being 0.25%. The complications, this block actually is a block with a lot of complications. You can actually have like Horner syndrome, chronic nerve block, recurrent laryngeal nerve block, epidural or subarachnoid injection, hematoma, intravascular injection,
local anesthetic toxicity, pneumothorax, and also nerve injury. But with the use of ultrasound, I think the incidence of complications can be reduced. Next, we move on to the supraclavicular block. Okay. So for the supraclavicular block, we are actually aiming to infiltrate local anesthesia in the above the clavicle at the level of the trunk of the brachial plexus. So the block distribution for this block, actually the distribution of the block is actually the whole upper limb except the proximal medial side of the arm. It also can provide a good analgesia or anesthesia for the shoulder, but not as dense as the interscalene block. So how do you identify the brachial plexus at the supraclavicular level? Because the subclavian artery crosses over the first rib between the insertion of the anterior and middle scalene muscle posterior to the clavicle. So you're able to identify the brachial plexus in relation to the subclavian artery and also the pleura and also the rib. So how you identify the rib? It is an acoustic shadow. Then the image view deep to the rib appears anechoic. For the pleura, you are able to identify sliding sign. Okay. So yeah, with the it is often possible to see the facial shift of the muscles surrounding the brachial plexus. And at this level, the brachial plexus can be seen as a bundle of hypoechoic round nodule, just posterior superficial to the artery. We use the artery as a guide to identify the brachial plexus. We are looking at usually about the depth of between 1 to 3 centimeters. This is also a very superficial level block. So this is the picture, the ultrasound anatomy to illustrate the brachial plexus at the supraclavicular level. So we identify first the subclavian artery, and then the first rib. So below the rib, you cannot see any. There's an acoustic shadow. There's nothing can be viewed because it's bone. The ultrasound cannot penetrate it. Then the pleura, you can see sliding sign. So the brachial plexus is viewed like a grape-like structure. Okay, superficial, lateral, posterior to the subclavian artery. So equipment is the same, similar to the interscalene block. So but we use a high frequency linear probe, but the needle length need to be a bit longer. So we usually pick about between 80 mm to 100 mm. You can also use 50 mm in smaller patients. So but the scanning technique, however, the patient need not to be in the propped up position. You can perform the block in the supine position, semi-sitting or slight lateral position with the head turned away from the side to be blocked. Something like this. So with this block, you will put the ultrasound probe in the supraclavicular fossa, and the tip is you need to tilt slightly inferiorly the probe. You need to tilt the probe slightly inferiorly to visualize the subclavian artery in the transverse view and the brachial plexus just posterior to the subclavian artery. Sometimes you need to rotate the probe in order to get a better view of the brachial. All right, sorry for the technical glitch. Yeah, but as I was saying, for this at this level also sometimes there will be arteries present, mainly the dorsal scapular artery again, transcervical artery and suprascapular artery. So this is an ultrasound image of the brachial plexus at the supraclavicular fossa. I guess you can see the dorsal scapular artery coming up from the subclavian artery just superficial to the brachial plexus, making the block very difficult. And this is another ultrasound image showing the suprascapular artery coming out from the subclavian artery, crossing the brachial plexus. So how you conduct the block? So confirm the landmarks under aseptic technique again, infiltrate the skin, and we usually advocate a lateral to medial approach. Even though there is also a medial to lateral approach, we usually conduct this block in the lateral to medial approach. And we insert the needle into the sheath. And when you're inserting the needle into the sheath, you often feel a pop. So the first injection should be directed towards the space, towards the junction between the subclavian artery and the first rib. We call this the corner pocket. So we directing the needle towards the rib is actually safer and avoid the pneumothorax. So at this corner pocket, usually we inject about 10 mils of local anesthetic in small aliquots. The aim is to float the brachial plexus superficially. After the corner pocket, we usually redirect the needle towards the superficial aspect of the plexus. So the whole objective of this is to have the brachial plexus surrounded by local anesthetic. So this is the ultrasound image to illustrate the block. So the needle first injection will be at the corner pocket, and the second injection will be superficial. So notice that actually you must infiltrate your LA in the sheath that contain the brachial plexus, and the aim is to surround the brachial plexus with local anesthetic. So the volume that we use for supraclavicular block can vary between 20 mils to 30 mils. And for the concentration is the same. So complications, the usual complication also, we can have nerve injury, hematoma, pneumothorax. Okay, thank you.
Thank you very much, Dr. Ng, for the informative talk. Now, to put it all together, we will have a demonstration of the two blocks. Our demonstrators will be Dr. Cairo and Dr. Nabila. Welcome, Dr. Cairo and Dr. Nabila.
Assalamualaikum and a very good morning. In this video, we will show you how to perform supraclavicular block for shoulder trauma. This block can be performed with the patient in supine, semi-sitting or slight lateral position with the patient's head turned away from the side to be blocked. Place a high-frequency linear transducer superior to the clavicle at the midpoint and parallel to the neck. To achieve the best possible view, the transducer must be tilted slightly inferiorly. The goal is to see the subclavian artery in the transverse view and the brachial plexus posterolateral to the subclavian artery. The first structure we need to identify is the subclavian artery. Subclavian artery is readily apparent as an anechoic round structure. This is the sonoanatomy that we need to identify. The brachial plexus can be seen as a bundle hypoechoic round nodules just posterior and superficial to the artery. We also need to identify pleura and first rib. These structures are linear hyperechoic structure immediately lateral and deep to the subclavian artery. We also need to identify middle scalenus muscle on the lateral side. Some describe the brachial plexus structure as a bunch of grapes. We are using Stimoplex 360 50mm needle using in-plane approach. To visualize the brachial plexus, the transducer is oriented in the sagittal plane until the first rib is seen deep to the plexus and the artery. So we aim first to deposit the LA at the inferior trunk of the brachial plexus. For analgesia, we are going to give ropivacaine 0.2%, 10 mils at this inferior trunk of the brachial plexus. We aspirate. Once there is no blood and clear, we inject the LA. So once we have created a space, then we push in our needle at the pocket of the brachial plexus. Next, after we deposit the local anesthetic, 10 mils, we flatten our needle, and the next aim would be the superior trunk of the brachial plexus. Once we feel a pop, then once again we aspirate and make sure there is no blood. We inject about another 10 mils of ropivacaine 0.2%. So total there will be 20 mils of volume. So this is the spread of the LA, and you can see the brachial plexus is flooded with the LA. Thank you.
Assalamualaikum and hi, I'm Nabila. Let's talk about interscaling block. So first of all, patient should be in a supine position with head slightly elevated and turned away from the operator. Patient's neck and upper chest need to be exposed, cleaned and draped prior block. So the most important landmarks here are the clavicle and the sternocleidomastoid muscle. High frequency linear probe is then placed transversely at the supragladicular fossa. Brachial plexus is identified, and then the probe is moved cranially until the grape-like brachial plexus change to a traffic-like appearance. Most of the time, the final probe position is at the middle of the neck, slightly posterior to the sternocleidomastoid muscle. Then, using an in-plane approach from the posterior end of the probe, the needle is inserted aiming towards C5 and C6 roots. Well, it is not advisable to insert the needle in an antero-posterior manner, as the phrenic nerve lies in between the sternocleidomastoid and the anterior scalenus muscle. Now let me highlight the important structure that we need to identify when performing an interscaling block. Well, this is an ideal sonoanatomy. It shows that the brachial plexus, more specifically the C5 to C7 roots, are being sandwiched between the anterior scalenus muscle and the middle scalenus muscle. So moving medially, the vertebral artery can be seen lying deep to the anterior scalenus muscle. Another important structure that we need to take note is the dorsal scapular nerve, which lies in the middle scalenus muscle. So the linear arrangement of the C5 to C7 roots reminds us of a traffic light or even a butterfly, with the wings represented by the scalenus muscles and the brachial plexus is depicted by the body. So now let's move on to the exciting part, which is the needling part. This is a superficial block, so the needle length shouldn't be more than 80 millimeter. So the needle block is slowly being advanced towards the brachial plexus, piercing through the middle scalenus muscle and then the nerve sheath. So the needle tip is placed between the C5 and C6 roots. LA is injected in a small volume, maybe roughly around 1 to 2 mils after negative aspiration. And we can see that the LA is enveloping the C6 roots. The needle is readjusted, so the LA distributed to C5 as well. So during the needling part, it is very important to ask the patient if he or she experience any pain during the LA injection. Patient might feel pain if the LA is being injected intraneurally. Post-procedure, the things that we need to observe are the common complications that can occur in an scaling block, like hemodynamically instability if, let's say, we inject LA inside the intrathecal or epidural, dyspnea if we block the pharyngeal nerve, even Horner syndrome if we accidentally block the stellate ganglion. A recurrent pharyngeal nerve blockade can happen, which gives rise to a hoarseness of voice. And lastly is the last, which is the local anesthesia systemic toxicity. So that's gist about the interscaling block. That's all for now. Till we meet again. Thank you.